Over the past decade, research has begun to suggest that physicians are using placebos in clinical practice, but evidence from Canada remains scarce. So for my master's thesis, I surveyed physicians in Canada on their use and attitudes towards placebos in the clinic by asking them a variety of questions. But when it came down to the most basic question, have you ever used or prescribed a placebo in clinical practice, this was the answer. 20% of physicians reported that they had. Compared to other countries, we see that this is pretty low. But when it came to exploring some of our other questions, we saw some very unexpected answers, especially because it seemed that many physicians were prescribing things without demonstrated or expected clinical efficacy. So, for example, giving vitamins for migraines or giving antibiotics, which are designed for bacterial infections, for viral infections. So what our survey began to reveal was that physicians had very different ideas of what constituted a placebo. And we started to see two different kinds of placebos. So the one placebo, the most popular definition that most people have and most physicians had, was this idea of a sugar pill or something that's biochemically inactive, despite patients still responding favorably to their use. But our survey began to show this idea of impure placebos, treatments that are pharmacologically active but not for the condition being treated. So this is the category that the vitamins and the antibiotics would fall into. Both pure placebos and impure placebos and a number of other factors influence the placebo effect. Oh, sorry. Which is a powerful mind-body phenomenon with a specific biology of its own. In light of these reports, medical associations began to form policies on the use of pure placebos in clinical practice. The German Medical Association recommends the use of placebos for certain conditions, and the American Medical Association, on the other hand, categorically prohibited the use of pure placebos. Canada has not yet made a formal policy. But this is exactly what my research in our lab is working towards. So this May, we're organizing a placebo conference and recruiting physicians, policymakers, and related experts to discuss the realities of placebo use in clinical practice. And ideally, we want to move away from this idea of placebo equals sugar pill and talk more about how we can capitalize on placebo effects and placebo-like treatments like impure placebos to improve the healthcare of Canadians. And of course, policy on this topic would have vast implications for a number of communities. For example, it could help shape medical education and how physicians are taught about placebos and psychosocial effects in medicine. It has implications for the pharmacological industry and the pharmaceutical industry, especially if their treatments and their products are no longer the first line of defense for certain conditions. And of course, it affects people and the patients and how they conceptualize illness, how they go about seeking treatment, and how they conceptualize mind-body effects. Thank you.
I was fascinated by the idea of the impure placebo, and just wondering in your research when you're trying to isolate the distinctions between, because part of it seems like the prescription part of placebo, the diagnostic and treatment part, has to do with intentionality. So you're moving from something that could be misdiagnosis to somebody that's conscious of diagnosing a placebo to somebody who's taking risks.
Yeah.
And how do you kind of define those different areas on the prescription side?
Yeah, on the prescription side, it's interesting because that was one of the questions that we sort of explored, was like the intentionality behind prescribing sort of these medications without demonstrated or expected clinical efficacy. For example, we found that for subtherapeutic doses, that was one of the things that physicians reported prescribing. And we found after interviewing, especially psychiatrists, that it depended on, for example, if they were receiving a patient and you start off a patient at a low dose, the idea is to start low and go slow to avoid side effects, and they would start to see a response in patients before they reached that therapeutic level, so they would stop treatment. But of course, they knew it was subtherapeutic and that it shouldn't really have an effect, but it did. So they would report, yes, I've given subtherapeutic doses without expected efficacy, whether that's a placebo or not. All I know is my patient's getting better. So, yeah.
But is that fed back anywhere in terms of subtherapeutic, again, anything with medicine is going to look for the norms across a statistical average. For that particular patient, it may have been therapeutic because
Yeah.
you're only you don't know what their body makeup is.
Exactly,
right?
yeah. And there's a biochemical individuality, yeah, and people are very different, and that's a big question in science too. Is we're always looking at means and the
Yeah.
standard deviation and how applicable is it to like one individual and
Yeah.
like a specific patient, and that's also I think a disconnect between physicians when they're dealing with patients and researchers that are dealing with looking
One
at
thing and then I'll give it to you.
overall averages. And
Okay, thank you.
thanks.